cancer is becoming more and more common, and breast cancer is commonest amongst the all cancer in female. So, I am Dr. Amit Chetani, oncophysician at Century Cancer Hospital, Rajkot. I am here to discuss what after diagnosis of stage 4 cancer. It would be very panic situation for patient and family after diagnosis of the stage 4 cancer. In stage 4 breast cancer, I usually divide them into two groups, whether it's oligometastatic or it's very advanced. If cancer has spread to at 5 spot only outside the breast and axilla, and if all the 5 sites are amenable to local therapy, which could be either radiation, surgery, RFA, or any other form of local therapy, then I label it as a oligometastatic cancer. In those cases, we usually start with chemotherapy plus or minus targeted therapy according to patient's HER2 status. Then we assess with PET CT scan or CT scan whether patient has responded to this treatment or not. If patient has responded to this treatment and there is no progression at any point, then I do recommend surgery of the primary tumor. Then radiation comes, which we give to breast and the all metastatic site if possible, or some form of local therapy at the metastatic site. Then the next phase of treatment will come, which will be remaining targeted therapy if patient is HER2 positive, and remaining hormone therapy if patient is hormone positive. So in such oligometastatic cases, we treat patient as a stage 3 disease, and in 30% cases we may expect longer survival also, even if they being stage 4. Now, if patient is very advanced and not falling into oligometastatic state, then we divide such cases into 4 groups according to their ER/PR and HER2 status. This group are ER and or PR positive, HER2 negative, ER/PR negative, HER2 positive, all 3 positive, ER/PR and HER2 positive, and all 3 negative, ER/PR, HER2 negative, which we call triple negative breast cancer. So I'll discuss for first group, which is ER and or PR positive and HER2 negative, if that is hormone positive cancer. Now in this group, if patient is very much symptomatic or having visceral crisis, that means the cancer has spread to one or more organ in such a horrible extent that the one or more organs function is very much jeopardized. In such cases, we need to act swiftly, and we usually start with chemotherapy. In remaining all cases, and if patient is not very much symptomatic, then we start with hormone therapy. That we decide according to menopausal status. If patient falls in postmenopausal range, then usually I do start with anastrozole or letrozole and abemaciclib, ribociclib, or palbociclib, one of 3. That we usually continue for 2 to 3 months, and then we assess the response with CT scan or PET CT scan or sonography according to site of metastasis. If patient is responding, then we continue it for another 2-3 months or 4 months, and then we again repeatedly check for response with imaging, and we continue same treatment till response. But at one point the phase will come of progression, where tumor will progress at one or more sites over the same treatment. Then I do recommend PIK3CA mutation test and ESR1 mutation test from blood or from the fresh biopsy specimen. If PIK3CA is positive, then I start with fulvestrant plus alpelisib. If ESR1 is positive, then elacestrant. But which is not available in India at present. If both are negative, then I do recommend single agent fulvestrant or combination of fulvestrant with everolimus, which we continue till response and progression over these drugs. Then we start and we switch to next line of chemotherapy. Then we start next line of chemotherapy. There are multiple chemotherapy options available. One after another, doctor uses to control the cancer and stop it for a while. In HER2 low positive, which means HER2 is +1 positive or +2 positive but FIS negative, in such hormone positive group, doctor may recommend trastuzumab deruxtecan also, but unfortunately that is also at presently not available in India. Now we discuss the second group, which is ER/PR positive and HER2 positive. In such group, if patient is very much symptomatic, then I usually do start with chemotherapy. My first choice would be paclitaxel or docetaxel plus trastuzumab plus or minus pertuzumab. We usually continue for 3 cycles. Then I do assess the response, how patient is responding with scan. If patient is responding, then we continue it for further 3 cycles. Then we continue trastuzumab and pertuzumab combination only, and on progression, second line anti-HER2 therapy, which I will discuss in later in this video. If patient is not much symptomatic, then I start with oral hormone therapy and anti-HER2 therapy, which could be trastuzumab or trastuzumab plus pertuzumab. That will continue till response, and on progression we can switch to chemo plus trastu and pertu or second line anti-HER2 therapy. Now we discuss the third scenario, third group, which is ER/PR negative and HER2 positive. In this group, we usually start with chemotherapy, and my first choice is paclitaxel or docetaxel with trastuzumab plus or minus pertuzumab, which we continue for 3 cycles, assess the response. If responding, then further 3 cycles. If responding, then we continue trastuzumab plus or minus pertuzumab, and on progression, we can go for trastuzumab deruxtecan, which is a drug antibody conjugate, and it gives response in 70% of cases, which is very good drug, but unfortunately not available at present in India. If that is not available, then one may opt for TDM1, which also gives good result. On progression on this drug, then trastuzumab, capecitabine, and tucatinib can be utilized, but tucatinib is also not available presently in India. Then on progression, trastuzumab, capecitabine, and lapatinib can be recommended. Now comes the last group, which is ER/PR HER2 negative, which we call triple negative breast cancer, which is very aggressive breast cancer. In this cancer particularly, any other breast cancer also, we recommend BRCA testing, MSI high testing, NTRK testing, and PDL1 testing. If any of them positive, then we can utilize some form of targeted therapy or immunotherapy according to result in a particular phase of the treatment. Usually if CPS is more than 10 of PDL1, then one can utilize chemotherapy plus pembrolizumab immunotherapy. In other cases, I usually start with paclitaxel plus carboplatin based chemotherapy, which we give for 3 cycles. Then I do assess the response. If responding, further 3 cycles. If still responding, then I put patient on oral tablet form of metronomic therapy. And if on that patient progresses, then according to BRCA status, MSI, if BRCA is positive, then olaparib can be utilized. If MSI high is there, then pembrolizumab can be utilized. In rest of the cases, we can switch to other form of chemotherapy that could be pegylated lipodose, eribulin, gemcitabine, oral capecitabine. In triple negative breast cancer, we usually start with IV chemotherapy. Then after 6 cycles, we switch to oral form of therapy. At one point, patient will progress, and then again we have to switch to IV chemotherapy. Then again, after response, we switch to oral form of therapy. So patient doesn't feel that that IV therapy is continuously ongoing and can have a break from IV therapy. But in triple negative cancer, the long-term survivals are not very good. So this was all information about stage 4 breast cancer. So friend, I request you to not to take any decision based upon this video. Better to believe in your doctor and follow your doctor's advice, because every patient have a different stage and different situation, and according to your situation, your doctor would be your best judge to decide particular treatment for you. Thank you.